My name is Dr. Robert Kerbel. I'm a professor at the University of Toronto in the Department of Medical Biophysics and a senior scientist at the Sunnybrook Research Institute, a University of Toronto teaching hospital. I've been doing cancer biology for over 40 years right now, and I'm interested in experimental therapy of cancer, especially of metastatic disease. I got interested in the idea, in retrospect, of what is called metronomic chemotherapy around 1990. And the reason is that I became intrigued by the idea, by the possibility, that conventional chemotherapy drugs that are used to treat cancer patients may be able to work in some cases not by directly killing cancer cells, but rather by killing the support network, the vascular blood supply that tumors need in order to grow and survive and metastasize. So the idea is that chemotherapy is normally designed to target and kill dividing cells in the body, and particularly, of course, in cancers where there are a lot of dividing cells. Well, one of the dividing cell types in cancer are the endothelial cells that line blood vessels that are feeding these tumors oxygen and nutrients in order for the tumors to grow, expand, and spread elsewhere in the body. And so I reasoned that chemotherapy might have an antivascular, what's called an anti-angiogenic side effect that would be good, that would help control tumor growth. And it was some years later that this idea was taken up by Dr. Folkman, who came up with a strategy to maximize, to optimize the vascular targeting effects of chemotherapy. He said that the way to do this was to give chemotherapy more frequently, and that meant giving it at lower doses. And in this way, you would be able to increase the number of endothelial cells and blood vessels that would be killed or stopped from proliferating by the chemotherapy. Metronomics today is still very much a niche concept. It is not yet widely accepted. There is no approved metronomic chemotherapy protocol. It is being adopted in some centers based on some recent randomized phase 3 clinical trial results. It's moving forward, I would say slowly but surely. But I would have to acknowledge and say that at the present time, it's still an investigational therapy. It's still being evaluated in various clinical trials around the world, and including very much so here in India, especially in Mumbai. You know, affordability is a big issue now everywhere, but particularly in low and middle income countries. That's obvious. When I say everywhere, even where I come from in Canada, or let's say the United States, the cost of new cancer drugs when they become approved and make it to market is rather alarming. A number of these drugs nowadays normally cost $5,000 per month of treatment. Some of them cost $10,000 or $15,000 or euros per month of treatment. So you can appreciate it. As we have an aging population, the incidence of cancer increasing because of the aging population, and you put that together with the cost of these new cancer drugs, which are sometimes used in cocktails. So the cost is just, it's unsustainable. And I think we, have to find ways of reducing the cost of cancer drug development and the cost of cancer care and treatment. And one way would be to use older off-patent drugs, for example, chemotherapy drugs, especially if they're going to be safe, if they can be taken by patients at home rather than in the hospital. And that, to me, is one of the major benefits of metronomic chemotherapy. If we can get more science-based clinical evidence that it actually works, that it's actually a benefit, I think the benefits really are enormous, especially for, countries like India. Well, there have been only a small number of trials initiated since 1990, probably maybe about 100 or so that have been completed that are called smaller phase 2 trials, but there have been a number of randomized large phase 3 clinical trials. I would say the aggregate results of which are encouraging, that are showing some clinical what we call survival efficacy benefit. So these trials were not outright negative, that means that there looks like there could be something there, and it's a step forward now, hopefully, to induce other cooperative oncology groups, other companies, possibly other investigators, to do more trials investigating this concept of metronomic chemotherapy. Well, the challenges that are faced by the investigators who work on metronomic chemotherapy they're multiple and diverse. It's still difficult, I would say, to convince many oncologists that giving lower doses of drug is a fruitful and logical way to go. Oncology has been dominated by the concept for more than half a century that of what's called the maximum tolerated dose. You give as much drug as you possibly can to a patient without killing them. And the idea is that the more drug you give, it may be more toxic, but it also may be more toxic to the tumor that you're attempting to treat. And so it's just counterintuitive for many investigators and oncologists to accept the idea that giving lower doses of drug would be a logical thing to do. One of my arguments, in fact, is that it's not necessarily that you're giving lower doses of drug, because you're also giving the drug more frequently, maybe even every day, over a prolonged period of time, so that the total amount of drug that a patient is getting may be equivalent to the traditional maximum tolerated dose types of protocol. There are other issues that have slowed, I would say, progress in this area, because a lot of the trials that are being done or that are thinking about being done, they utilize oral chemotherapy drugs. Now, there's obviously an advantage to that. Patients can take the drug at home. They don't have to come to a hospital or a cancer clinic and be hooked up to an intravenous infusion device. That's a big advantage. However, economically in certain countries, actually physicians prefer the intravenous injection route because there's a fee for service, as opposed to writing a prescription for a patient and taking an oral drug at home. Unfortunately, there's an economic incentive to do things the older way. Also, some oncologists feel that they like the infusion approach because they know exactly how much drug a patient is getting, and they know the patient is getting the drug. Whereas when patients take oral medications, they may not be always taking their pills. They may forget, or they may just not want to, or there may be variability from one patient to another about how much drug is actually getting into the bloodstream from the gut, how much drug is actually being absorbed. So again, this relates to the whole issue of oral medications, which are perfect for, or ideal for metronomic chemotherapy, versus, intravenous infusions. And again, using off-patent drugs, well, you can appreciate that a lot of pharmaceutical companies would not be particularly enthusiastic about that idea, because there's no, little incentive from a profit point of view, and drug development in oncology is extraordinarily expensive. Well, that's one of the appeals and one of the attractions about metronomic chemotherapy. The side effects are less. It doesn't mean that there are no side effects, but the side effects are less. So that, for example, with a lot of the metronomic chemotherapy protocols that have been published, there's very little hair loss, very little myelosuppression, loss of your white blood cells or platelets, much less nausea, much less vomiting, much less in the way of rash or fatigue. I mean, these are significant advantages for the quality of life of cancer patients. However, significant as they may be, they have to be balanced. They have to be shown that there's a benefit. There's an actual significant benefit to the therapy. Again, there are some oncologists who say that toxicity, as unpleasant as it is, may be a sign that the drug is working on the cancer as well. So in other words, toxicity is a kind of a sign, a surrogate for the drug working on the cancer. And therefore, the argument follows that if there's very little or no toxicity to a cancer therapy, it may not be doing anything on the cancer. And maybe in some cases that's true, and in some cases it may not be true. But I'm simply saying that these are amongst the arguments that some researchers and some oncologists and some company executives and researchers will say, okay, in some ways the metronomic chemotherapy concept is interesting, but there are also some potential significant downsides. And all of this really means we have to do the requisite clinical trials in order to show indeed that the drugs that are used for chemotherapy and the protocols used are safe, are tolerable, but are also effective. I wouldn't say that metronomic is the future per se. I see it being included and being used alongside many other therapies. For example, currently the hottest thing in oncology right now is harnessing the body's immune system to fight cancer. Very, very amazing, exciting things being seen with what are called immune therapy drugs. But again, these drugs are extraordinarily expensive, and they don't work in most patients. When they work in patients, they work amazingly well in many cases, but in a lot of other cases, they stop working or they just simply don't work. So investigators around the world are trying to, just as an example, design strategies to take, say, one of these new immunotherapy drugs and get it to work better by combining it with something else. Now, there's a logic to combining, say, an immune therapy with something that's less expensive, because the immune therapy drug itself is very expensive, and that might actually boost the efficacy of the immune therapy. And metronomic chemotherapy might be one such strategy. There are examples of certain drugs, old off-patent drugs. One is called cyclophosphamide or endoxan, and that drug has been known for years to stimulate the body's immune system to fight cancer. So it would be a logical drug used metronomically to be combined, for example, with an immunotherapy or a tumor vaccine, or other classes of anti-cancer drugs, including, for example, anti-angiogenic drugs. So what I foresee is it doesn't replace the way chemotherapy is being done, but rather it's used in conjunction with traditional chemotherapy. It's used in conjunction with other therapies, and in doing so, it may reduce cancer care costs and it may make it more convenient for cancer patients.